I am very excited and only slightly delirious. It's been very fun on teaching service. It's been very busy, but I'm really excited for today. Um, I have the privilege of discussing this case with the one and only Mingyu. Do you want to say hi?
Yeah, I'm so excited to be first time co-discussing with Charmin, and I'm always impressed when someone can join VMR to discuss when they're on service. I would be totally delirious. I'm also impressed that Maddie, only week 2 in intern year, already have not just one case to share with us. So I'm very excited for your case and a little bit nervous too, Maddie.
Right? I mean, Maddie is just a star, like a rock star of status. Maddie, thank you so much for presenting the case today. Shout out to Valley for scribing and Parisa. I can't wait to hear your teaching points. Maddie, do you want to unmute and say a quick hi?
Yeah, hello everyone. Nice to see so many of you. Yes, the case I'm going to present was a case I saw last week, and now week 3 into residency. And I feel like every time I see a case, I'm kind of always thinking in the back of my mind, how can I share this with the VMR family? So as soon as I saw this open case presenter slot, I was like, oh, gotta grab it to share all the different cases I'm seeing. But really excited to present to you both.
Wonderful. I can't wait, Maddie. So whenever you're ready, get us on the way.
All right. So for the first aliquot, so we have a 33-year-old man who presented to the emergency department with abdominal pain, nausea, and diarrhea for 8 days. So the story goes that about 2 days into the pain, so 6 days ago, he actually went to a different ER with similar symptoms of abdominal pain and nausea. They treated him symptomatically with anti-nausea medications and then discharged him with return precautions without further workup. But the symptoms persisted, so he presented to the hospital where I eventually met him. So he says the abdominal pain is worse in the left lower quadrant. And since the onset about 8 days ago, he's had really persistent abdominal pain, nausea, and also some worsening abdominal distension. In this time frame, he's also had diarrhea that happens 3 times a day with occasional blood on the toilet paper. So I will pause there.
Yeah, I love such a rich case already, Maddie, the first aliquot you presented. So when I hear abdominal pain, I first always think about the can't misdiagnosis, just to screen that in my mind, which includes the VIPO mnemonic that we use, like vascular inflammation, perforation, and obstruction. And then if there's a localization, I use that to kind of then map into the anatomical approach to see which organ system could it be. So like now it seems to be mapped into the left lower quadrant. So in that area we have, I mean, first, if we apply the thought tree, always consider the referred pain. Since it's lower, it's less likely to be cardiac, like lung up above, but it could be pelvic, referring to the lower quadrant. So I'll consider that. But if it's since it's male, not going to think about ectopic pregnancy, but that would be one of the can't misdiagnosis in female patient of this age. So lower quadrant, left lower quadrant, I think definitely bowel, like colitis or diverticulitis, came to mind, especially with the diarrhea that has the blood in it. Seems to be really deep in the bowel. So I will that's where like my mind is right now. What do you think, Charmaine?
Oh, yeah, that was fantastic. To kind of think about like always anchoring yourself in the no misdiagnosis. Yeah, I'm worried about this guy, right? Like he's 33 years old. This is the second time he's coming to the ED. Like, young people tend to not like to come to the emergency room. So when they're like presenting to care, oftentimes, as you mentioned, like you want to take it quite seriously and making sure you're not dealing with any of the the beautiful emergency causes, the no misdiagnosis that you were telling us about. And they're similar to you. Yeah, I think about the abdomen and I just do a quick glance to like the thorax and the pelvis, as well as like the neighbors of the abdomen, to make sure it's not kind of a referred pain as you were alluding to. And like in the pelvis in a young man, thinking about like also testicular torsions and those things, it comes to mind as well. So a couple of things, this is we're dealing with like an acute worsening abdominal pain, with like the diarrhea, the nausea, as well. That again, like it kind of maps to our GI tract. One thing that often is very common in all comers is like colitis that kind of like goes through all of the quadrants. And that can, kind of thinking about like infectious colitis in general, gastroenteritis, those things. That oftentimes can commonly present in young people. He didn't really was like complaining of any like fevers, any nauseas, or any like any of those things as well. The one thing that I always like want to make sure whenever people are nauseous, vomiting, and with abdominal distension, like it's a bowel obstruction. So especially with the distension, oftentimes when people are distended, we're thinking about different phases of matter. So is it gas, is it liquid, or is it solid? The time course makes solid a little less likely unless like you're bleeding into a space that turns into a hematoma. Again, a week or so, a little less likely. So thinking about gas or fluid accumulation. And with this kind of symptomatology, just making sure he doesn't have any obstruction. Um, I think in terms of like the diarrhea, again, I think the question is like, is the diarrhea just a downstream consequence of whatever is happening in the GI tract, or is it the main event? Is that the diarrhea that is now causing the abdominal pain? I think with like a more exam and also labs, that would be informative. The other thing that, whenever I think about diarrhea and like my no misdiagnosis, uh, like C. diff, we often think about like antibiotics, but now community acquired C. diff is a lot more common. So I think especially if the diarrhea that is like kind of with someone who's sick appearing. So thinking about like C. diff complications of that, like a toxic megacolon that can cause some distension, some ileus comes to mind as well. One other thing that I think it would be informative is just again like know who this patient is. Is he like a healthy 33-year-old, no medical conditions, or is it someone who has like chronic medical conditions that would make him more at risk for organisms or infections that we often don't think of in immunocompetent people? So that piece, like any history, any exposures, any history of like travel, I think would be informative as well. In terms of like the blood on the toilet paper itself, like often makes me think of hemorrhoids when people say that, like especially if it's not seeing. So yeah, the question is like, is this bloody diarrhea or is this diarrhea with like blood on the toilet paper that moves into hemorrhoids? Oftentimes, like when I'm on admitting a patient like this, I just always like go to our nursing staff and ask like, hey, can you just like save a sample so I can just take a look at it? Because what I found out practically is hard to be on the same page on what is diarrhea actually. Are people having diarrhea? Are they having loose stools? Is it actually bloody diarrhea? Is it just like few drops of blood? So I think that would be informative. And then like I think hemoglobin will also help us in the scenario as well. Um, there was one other thing that I was going to say that I no longer remember, but it'll come back to me if it's important. Maybe any other thoughts before we move on? I think you're muted.
Sorry, yeah. Not at this point. I look
Yeah,
forward to Maddie's
yeah.
next eloquent.
Oh, I remember what I was gonna say. Oh, diverticulitis on like often I think of like people that I see the most common with diverticulitis tend to be like older folks. So if this is a young person, and if this is like something like left lower quadrant, we often assume associate with like diverticulitis, and I worry about like some more like congenital or hereditary causes that can predispose people or like severe constipations. The other thing is that like, oh, is this person was with like the diaper in the blood was like had history of constipations before. But again, it would be a little um yeah, it would be interesting if this is diverticulitis in someone who's like quite young. All right, Maddie, back to you.
All right, loving your discussion. So on to aliquot 2. So review of systems notable for nausea, also some vomiting about once or twice per day for the past 8 days, in addition to the abdominal distension and abdominal pain he's having. No fevers, chills, headaches, rashes, weight loss, shortness of breath. For past medical history, he has a past medical history of migraines, also a seizure disorder. The last seizure was about 17 years ago, and he takes carbamazepine for that. He also has a past medical history of constipation, no recent antibiotics or hospitalizations. Past surgical history, he had a fundoplication surgery for acid reflux. And then medications only include the carbamazepine, no other medications, and no frequent NSAID use. No pertinent family history. Then for social history, so he lives at home with his wife and 3 kids. He works in waste management. No recent travel history. He was born in El Salvador, but has lived in Colorado for about 10 years. And in terms of health-related behaviors, he reports periods of binge alcohol drinking with sometimes up to 10 to 12 beers on the weekends socially. Moving on to the vitals. So the vitals, the temperature was 37.5, heart rate 98, blood pressure 127 over 86, sat 92% on room air with a respiratory rate of 25. In general, in the ED, he appeared uncomfortable. Cardiovascular and pulmonary exams were normal. For the abdominal exam, the abdomen was markedly distended with tenderness to palpation diffusely, but most prominently over the left lower quadrant. There was no rebound tenderness or guarding. Neuroexam showed no focal deficits, and there was no rashes or edema on the extremities. And then just because we'll have a bit more data, I thought I would give you some initial labs before pausing. So the CBC showed a white count of 10, predominantly neutrophils, hemoglobin of 14, platelets of 288, and the BMP with a sodium of 132, potassium of 3.2, chloride 103, bicarb 22, BUN 11, and creatinine 0.79, AST 65, ALT 69 with an ALK phos of 111. And I'll share that the CRP was 120 and a lipase of 30. And I will pause there.
All right, I'll take the past medical history and then pass the mic to thank you for her thoughts on the exam and the initial labs. So, in terms of like a past medical history, uh, we get the history of like constipation, which kind of like makes in with going back to the HPI that we were the blood on the toilet paper. Potentially, we were concerned about diverticulitis with history of constipation that potentially could be compatible. So that is like one possibility. In terms of like the surgery for the reflux, I'm not sure how. I don't know much about this type of surgery. So what I tend to do in real life is honestly actually just read about the surgery and potential complications of it. Oftentimes when there's been surgical procedures, the things that you worry about, if there was anastomosis, if there is any leak there that could potentially cause any, or perforations that any causes it. Sometimes some of the surgeries can affect your absorption, which is like less likely to be related to this procedure. Or sometimes like with any surgical procedures, you would worry about like scar formations and if that is at play here. But again, I don't know about specific of this surgery, so this is something that I would be looking up in real time. In terms of like his medications, thank you for the no NSAIDs use. So thinking about, kind of peptic ulcer disease, abdominal pain, that the NSAIDs can be at play here. And, in terms of like his seizure disorder with being on anti-seizure medications, again, I'm not sure how that could be related, although like, medication side effects is always something good to make note of as we go through the case. In terms of like his exposures, thinking about like someone who like works in waste management, It kind of has like whole slew of exposures to toxins. It can potential to infections. Rodents often like to find their way into waste. So kind of thinking about like if they have any recent exposures. Um, in general with exposures, I like to make a note of them. I think it's so easy to anchor on exposures when we see them. However, you want to make sure it's a compatible history and also like common things being common. Sometimes like these exposures in reality are not the most common things we see. The alcohol use is interesting. So thinking about his alcohol use disorder, if thinking about like, okay, when was his like last drink? And oftentimes even with binge drinking, like people are at risk of developing like alcoholic hepatitis, acute liver failure of some sort, and potential ascites. Again, someone who's coming in with distension and thinking about how those fluids could accumulate. So I think we could thinking about again the gas or the water as well. In terms of like, alcohol use definitely puts you at high risk of peptic ulcer disease as well. So again, we're not the diarrhea with the blood. I'm not truly convinced that this is a GI bleeding, but something to like keep an eye out for as we go through the case. All right, Mike, to you.
Yeah, so I think just focusing on the exam and the initial labs, I overall I get a little bit sense of some early signs of SIRS or sepsis here, because of we have some mild temperature elevation, although not in the fever range. We have some mild a little bit tachycardia, um, tachypnea, although the blood pressure is fine at this point, and then we have some neutrophilic leukocytosis, it sounds like. And then we have elevated CRP suggesting like acute inflammation. Also like the mild hyponatremia seems, well, I think that could also go with the diarrhea, some volume depletion, along with the hypokalemia from like a GI loss. But overall, I get a sense of some early SIRS. So like there's acute inflammation that we have to pay attention here and to prevent it from going and developing, if it's an infection, to not develop a more severe sepsis or septic shock here. But then taking a step back, like what else could cause this kind of SIRS picture, we know that there's something likely going on with likely in the bowel in the left lower quadrant. So like definitely colitis, diverticulitis are still pretty high on the differential. But then also thinking about if we consider, I think some imaging will definitely be helpful here to help us localize. And then some initial, some potential empiric antibiotics would be useful, and some stool workup, stool cultures. But then trying to think like what specific like other conditions that could mimic this, so or could be causing this, especially in a young patient. I think vascular seems a little bit less likely in this young patient who doesn't seem to have smoking history or any other vascular risk factors. And um, um, but then yeah, I think that's where my mind is. I was gonna say, and then immune status is very important to help us see how broad our differential is in terms of if it's an infection, like the infectious agent here. Yeah, I think there's common pathogens. If it's thinking of an infection, could be like some of them are mapped related to like travel exposure history, which I don't see too much here in acute, like no recent travel. But then I'm also curious the waste management. How does that contribute to the could be a potential source of infection? I think I'll pause here. Yeah. Any other thoughts, Charmaine, or should we move on to the next aliquot, Maddie?
Oh, I have absolutely nothing to add. That was great. Go ahead, Maddie.
Yeah, absolutely brilliant. I really love listening to hear both of you discuss this. So to your point of the immune test, so the HIV test was negative, and I'll share for this aliquot the findings from the CT abdomen and pelvis that were initially ordered in the ED. And the findings showed diffuse circumferential thickening and inflammation of the sigmoid colon, focal narrowing of the proximal sigmoid colon with moderate upstream colonic dilation and colitis, substantial fat stranding within the left lower quadrant without a discrete drainable abscess, no pneumoperitoneum. They also commented on a colovesical fistula from the thickened sigmoid colon extending to the thickened bladder wall, possible fistula between the proximal and distal sigmoid colon. And we'll also share that a fecal calprotectin that was sent was elevated to 321. And I'll pause there.
Wow, yeah, I guess I'll start with this aliquot. Very interesting imaging findings, and almost a little bit surprising with the fistula that seems to be like a, I don't know if it's pathognomonic, but definitely raises the concern for not just the common infections, but like a more deep inflammatory process, like Crohn's disease, have a tendency to cause fistula, along with the lab finding of the calprotectin elevation. So I think definitely my mind goes to Crohn's disease. Like on my differential for acute diarrhea, although the majority of it is infections and the medication is something we always think about, which is not present in this case, then IBD is also on the differential. Like maybe it's the first presentation of IBD in a patient, although we tend to associate that with chronic, but then could definitely be the initial presentation of IBD. And with this imaging finding, I think, yeah, I think that's still very concerning for this patient. And the biopsy, I'm sure, yeah, I guess if the GI doctor might, I feel like practically they might suggest, well, without the fistula, they would definitely say treat empirically, then consider maybe an outpatient, not outpatient, but like a subsequent colonoscopy, because you don't want to do colonoscopy in the acute infectious setting. But with the fistula, I assume we need some pathology here to confirm. Yeah, what do you think, Sharmin?
Yeah, absolutely. Like definitely, it's definitely has the flavor of IBD to it, doesn't it? With like the fistula. Yeah, the time course is interesting, although I guess like any chronic inflammatory disease has to start with something. And I wonder if like something served as a trigger, or if we go back, maybe he's had some symptoms in the past as well, that would like kind of points to that. But yeah, definitely I agree with you. As I was like hearing this, I'm like, oh my gosh, that's like, is that with the abscess sorry, without the abscess formation, like with the visualization and everything, definitely invokes Crohn. I was like kind of think about like, okay, what can be potential mimickers that we shouldn't miss? And I think the big one was like kind of HIV and all of the associated infections like that. It sounds like the HIV test was negative, if I heard you correctly, Maddie, correct? And then the other one is like, the great TB that can do anything it wants and can definitely kind of mimic IBD. Although I have never like honestly have heard visualization with that, but it's always like on my list of things to think about. I mean, you mentioned that like NSAIDs used that can cause kind of like a colitis type picture as well, which again he doesn't have here. And the last one is a lymphoma that can also act similar to IBD in the colon. Um, and uh, and he doesn't. The other thing that I always like also think about is like kind of the extra GI manifestations of IBD, which again nothing here jumps out to me um, as related to that. So I think in general, just to make sure, if we think about like, oh, what is like the therapy for IBD would be immunosuppression, or sometimes like oftentimes they might like start with something more local. But given I think you just want to make sure he doesn't have any overlying infection in addition to that, and that didn't serve as a trigger for it. So I would like to kind of, as Mingyu mentioned, just kind of the studies, stool studies to be sent out. He is definitely acting inflamed, so I think nobody will fault you for drying cultures as well. Again, these people, especially with visualization, you're at risk of translocation as well. And thinking back to the blood that we saw, is that the visualization as well that could be playing a role on that in that. So um, and I feel like the timing of the colonoscopy is a really good one, and I think that's something that I would just ask GI colleagues about, like whether it's when things are inflamed, oftentimes they don't like to go in. Although, like with IBD, I've definitely seen them do a colonoscopy versus like for infections or diverticulitis, they always want to hold off. So that is something to really to kind of yeah reiterate with them and see what they say. Fascinating. Maddie, what happened next?
Yeah, all right. So as you both mentioned, so at this point, GI and surgery were both consulted. Surgery said that there was no indication for surgical intervention at this time. For GI, and actually, just to be kind of fully transparent, so actually the CT abdomen and pelvis, the radiologist said at the end, constellation of findings is favored to reflect Crohn's disease. And GI, when we first consulted them, also meant that this is concerning for new penetrating and stricturing Crohn's, although other infectious, inflammatory, ischemic etiologies need to be excluded. So both, as you both were thinking, that's kind of the thinking of the team at this point as well. So GI recommended starting methylpred, 60 milligrams once, and then 30 milligrams BID given, they wanted to trial steroids given that the sigmoid stricture was likely inflammatory. They recommended to get an abdominal x-ray to evaluate colonic dilation, and then the plan was to do a flex sig with biopsy. And the abdominal x-ray showed colonic gaseous dilation measuring up to 9 centimeters in the mid-transverse colon. And I'll read the findings from the flex sig with biopsy. So the findings from the flex sig was moderate diverticulosis in the sigmoid colon, narrowing of the colon in association with the diverticular opening, with colonic dilation proximal, with peridiverticular erythema. There was diffuse severe inflammation in the descending colon with edema, erythema, friability. And there was a single 10 millimeter ulcer found at the splenic flexure that was biopsied. So after the flex sig, the GI's recommendations was to follow the patient clinically with daily abdominal ultrasounds, IV antibiotics, and await the pathology results. So we started the patient on ceftriaxone and metronidazole while we awaited the biopsy results. And I'll pause there.
All right. So yeah, I think it definitely makes sense to start this patient on immunosuppression. If it like sounds like Crohn is acting like Crohn's, and given like the complications of Crohn's that we're already seeing with like the visualization and the strictures, I can totally understand the need for that. And I'm glad they didn't stop there. So thinking about the ulcer that was fine, that is not something that that I associate um uh with with Crohn's as much. Thank you. Am I wrong?
Um, I'm trying to remember. I think like for ulcers, there's like some differential, like Crohn
Mm,
would be one. Also, I think UC ulcerative colitis would be more
yeah,
classic, like causing
yeah,
ulcer. And then you have
yeah,
to differentiate depending on the location or the whether it's longitudinal or transverse. It
yeah,
could
like the
be
skip lesions, right?
yeah, it could be
Yeah.
your viral infection there.
Yeah, yeah, exactly. And like kind of going back to that HIV testing and making sure the patient wasn't in the window that is negative as well. And thinking about like any viral etiologies that could cause that. And the other thing that I'm always like suspicious with these type of finding is like, is there an underlying GI malignancy that we have to worry about here? And like kind of like infiltrative infections are often like kind of notorious for doing this. However, like the stricturing like it's very much like IBD focused. So I think the question is like whether just are we dealing with like an IBD plus something else. Minky, what are your thoughts?
Yeah, I was thinking like part of the case almost seems like an ulcerative colitis with the
Mm-hmm.
ulcer and the sigmoid colon involvement, even though we don't see any rectal. But part of it is, so maybe it's like if it's IBD, it might be like a overlap. But I think like I feel like fistula and strictures are maybe more common in Crohn's
Hmm.
disease. I mean,
Hmm.
that's why they thought about that. Even without any biopsy, they kind of was very convinced that was the case. But then, yeah, I definitely think could be something on top of it too. Like I mean, a splenic fracture of fracture is where like there's some ischemic event could happen, but I still don't think like in this young patient, I'm not thinking about vascular specifically there. Uh, I remember if it's like terminal ileitis, which is like more classic Crohn's disease, initial location with some enriched differentials, I think then definitely like, could be like any Shigella appendicitis, Shigella TB, Behçet's, anything like tend to be to. But this is like an interesting location for the ulcer to be. Yeah, I'm a little puzzled. I wonder if it's still just part of the IBD presentation.
Yeah.
Um,
Yeah, I totally agree. I was like kind of thinking through like, oh, I'm always like live in a fear of like mimickers. And is there any mimickers that we need to think about? So I think like yeah, chronic granulomatous diseases tend to with like ulcerations, the other autoimmune disease that cause ulcerations like an Behçet's that at times can also mimic IBD. Again, like I don't think I've seen enough cases to know if it would cause like the visualization or the stenosis that we see here. And I think we mentioned kind of like, yeah, again, I think, yeah. So that's another possibility to think about. But uh, I agree that, sometimes like treatment is like the best diagnostic test. So whether he gets better on worse on steroids, I think would be informative to see like if you have if you're on the right trajectory or not.
yeah, and speaking of treatment, I almost think like a UC is easier to treat, like more responsive versus Crohn's disease. Sometimes you have to jump to biologic agents. Like some people don't improve, or I think some people they do improve, but they don't resolve their symptoms completely with just steroids. So, uh, yeah, I wonder if Crohn's disease is more at play if it's still IBD here.
Yeah. Yeah, for sure. All right, Maddie, what happened next?
All right, so after a few days, the biopsy results returned, and in the descending colon, the biopsy showed acutely inflamed granulation tissue consistent with ulceration, with colonic mucosa with features of quiescent colitis, but no crypt abscesses identified. The transverse colon, it was mentioned ulceration, but no active or chronic colitis identified. And there were no granulomas nor ischemic changes. And the pathologist specifically commented that it's unusual to have the extent of ulcerative changes without active inflammation of the associated colonic mucosa in primary IBD. And there's more to the story, but I can pause here in case either of you want to share your thoughts, and then I can share the next the next thing that happened.
Oh, any thoughts, Minkyu?
Mm, I'm trying to catch up on what Maddie said. So like
Mm-hmm.
the expert said the ulceration is atypical for without active inflammation is atypical for a yeah, but I think now we have additional information, which is the granulomatous changes. So I would like review my granulomatous.
Oh wait,
Uh,
I just want to clarify, there were no granulomas. Just want to
oh,
be
no
clear.
granulomas. Sorry. Oh,
Yeah.
hmm. Oh, granulation tissue. Yeah, sorry, I misread that. Yeah. I'm curious if there's any extra intestinal findings that can help give us a clue, but sounds like we don't see them yet. Hmm. I don't know. uh, yeah, I just thinking about the ulcers. Remember, like there's TB, Behçet, like they have one has like longitudinal, one has like transverse, but I can't quite remember which one is which. but we don't see other symptoms of Behçet's disease here, to like oral ulcers or gentle ulcers. Yeah, I'm curious. Look forward to learning more from you, Maddie. How about you, Sharmin? Any other final thoughts?
Yeah, I think yeah, I'm like the one that comes out to mind was like Behçet too, because I feel like the ulcerations are just such a classic presentation of it. To be honest with you, I do not remember what it looks like on biopsy, whether this could be it. And I like your idea of like I'll like going back and figuring out if there's any extra clinical like manifestations of that, like especially with Behçet's or even like IBD, like some of the ocular findings are very helpful. So like whether like an opto eval here would help us make some diagnostic progress, um, as well as like I think, just making sure in terms of like mucosal services, if there's any oral ulceration. I think the hard thing about with like Crohn and Behçet is that like Crohn can also cause oral ulceration as well. But I think like given that there is no pathognomonic findings here. That being said, also like these diseases sometimes the question always also becomes like, oh, did we just the sample we got did not have enough of that clinical finding, and whether like a repeat biopsy would be helpful to clinch the diagnosis. So that's something that I would kind of ask our GI colleague as well, is that like, hey, is it worth resampling in this patient um or not? But yeah, I think like some of the vasculitides are often, but again, like it doesn't really doesn't have kind of the flavor of vascularity here as well. Sometimes they also can have ulcerations too. The other thing is like sometimes with Behçet, with both of them, you have like erythemanodisms, like especially with Behçet, I think you can find that commonly as well, more common in women than men. So yeah, I think I would think about IBD mimickers a little harder now, and then also thinking about like, oh, is it a possibility that we could have just missed it on biopsy? Maddie, teach us.
Yeah, no, yeah, I think the team was thinking that along the same lines as you. So just to kind of give an update as to what was happening with the patient at this time. So each day the patient was getting an abdominal x-ray per the recommendations to monitor the dilation, and general surgery was following, and still there was no indication for intervening surgically with the biopsy findings, and there was actually improvement in the dilation on the abdominal x-rays over the few days. And this was actually the point where I started taking care of the patient. Previously, it was another intern, and then she passed this patient off to me when she went off service. And so a few days after the biopsy, I saw the patient in the morning, and the patient was actually feeling a lot better, and had some improvement in his pain, but was still reporting some left lower quadrant pain. And when I went to go see him, I noticed that the abdomen was still, markedly distended. So I ordered another abdominal X-ray kind of before rounds, and my plan was on rounds to kind of talk about even the potential of maybe switching to PO antibiotics, given that the patient was feeling better and the labs were kind of stable, and he seemed to be improving clinically. And then in the middle of rounds, I got a call from the radiologist who asked me to order a stat CT abdomen and pelvis, given some concerning findings on the abdominal X-ray. And I can actually show you those photos. So let me go ahead and share my screen. Sorry, let me find the share screen button. All right. Can you all see this? So
Wow.
I have, this is the abdominal X-ray from a few days after the biopsy, and I also have the CT abdomen and pelvis that I can show. Let me know if you want me to go straight to the CT abdomen and pelvis, or if you want to make any comments here.
Ooh, just the distension has me incredibly worried. So yeah, it's, incredibly distended. Yeah. What's the CT show? I thought, and the thing that I know he has a stenosis, but I think like kind of perforation, transition points are the things that I would be looking for.
exactly. So let me show you the CT abdomen and pelvis. Is this playing? Let me go a little slower.
Oh gosh, is that gas? Oh,
Yeah.
okay. So yeah, so thinking about perforation. So at the top of this screen, you can see free gas in the abdomen, which is incredibly concerning sign for perforation and thinking about like this patient being at high risk of peritonitis. Uh, and you know, yeah, I think is a Austin great point. I was just thinking the same thing is that like, with steroids, oftentimes, the abdominal exam can get a bit masked. So yeah, I would be calling surgery ASAP stats.
Yeah,
Yeah, go ahead. Mengyu.
yeah, I don't have too much to add. I agree. It's very concerning, but wondering how that, yeah, was how the inflammation went really deep and caused this perforation, and that, yeah.
Yeah, I
It's
think like the ulceration, right? Like he had the ulceration, he had like yeah, he had like multiple reasons as to why he could have had perforation. Yeah, I think in the meantime, like in terms of like management, I mean, you like, well, if you were in Maddie's shoes, anything else that you've been doing, you would be doing?
I think I would really rely on our surgical colleagues here.
Yeah. Yeah, I think just like close monitoring, making sure, close monitoring his abdominal exam, making sure he's NPO, uh, making sure like you have good access, like getting good vital signs, brought in those antibiotics for now as like kind of a bandage, making sure like your fluids are ready, and yeah, so like close monitoring, come asking surgery to come to the bedside stat, with that CT finding kind of
Yeah,
what I would
totally.
be
Usually, yeah.
doing. Yeah. All right,
Usually these
Maddie.
patients will be put on like Zosyn along with all the things you mentioned. Yeah.
Hmm. Yeah, like a great abdominal coverage. This time is not the time to think about antimicrobial stewardship. But I think I would just also ask for forgiveness later and Zosyn. All right, Maddie, what happened next?
Yeah, I mean, your read was spot on. So basically, that CT abdomen and pelvis showed new large volume pneumoperitoneum and findings compatible with a bowel perforation favored to be from the left colon. Um, Re-demonstrated findings that are likely due to large bowel obstruction with the transition point in the distal left and proximal sigmoid colon, which could be due to the colonic stricture. And then there were increased inflammatory changes of the colon extending from the proximal transverse colon through the sigmoid. Then there was the re-demonstrated colovesicular fistula. So as you all said, kind of we got surgery, called them right away, and the patient underwent an XLAP, and he ended up getting a left hemicolectomy and a loop ileostomy. And when I was reading the surgery note, it said that the left colon was found to be severely necrotic with a massive perforation distal to the splenic flexure, and kind of dense adhesions between the colon and the bladder wall. So ultimately, that's when I this was just a few days ago, and I last checked the patient's chart, and he's in the SICU, kind of recovering from the surgery, and there have been some complications, which is really unfortunate. And so I think the final diagnosis that that's we were able to kind of put together was basically this severe colitis that was complicated by fistulas, strictures, a large bowel obstruction, and then ultimately a perforation. And in terms of the etiology, so exactly as you all were saying, kind of with the initial imaging and with the fistulization, I think there was a lot of concern for IBD, specifically Crohn's. Um, but I think that was the biopsy did not show kind of the what you would expect for that. And so I think the I think it's presumed that potentially this is all complications of diverticulitis, given kind of the moderate diverticulosis and kind of the surrounding inflammation that was found on imaging. And, as we know that there can be so many complications from diverticulitis, including strictures and fistulas and, then subsequent obstructions and perforations. So, I think there is some diagnostic uncertainty here, but I think one way to put this together is all of these kind of complications from diverticulitis. But I agree that it's atypical for kind of a younger patient. So I'm not 100% confident in that, but it ultimately was just a very humbling case of a few things. One, just like how quickly things can change. Like the patient was feeling better and the team was even thinking of transitioning to PO antibiotics, and then we got a call from the radiologist and things really really took a different course. And also just very humbling to see like if this really was you know all of these complications from diverticulitis, just how damaging that can be. So that's what I have for the case.
Wow, that's such a dramatic case. Unfortunate for the patient to have so much complications, but I do remember, Maddie, you had a wonderful schema episode on the podcast, as well as a like a visual of a diverticulitis complication. So I'm like reviewing that. I see all these things like kind of mentioned the fistula, your very cute picture there, like with the bladder and the abscess perforation. But this case is really mind blowing. Definitely a lot to learn and read about further about the severity of diverticulitis here. Yeah.
Yes. Wow. I'm, yeah, this is like such a humbling case. And I agree with you, Mengyu. I feel like diverticulitis can like definitely humble you. And yeah, and I'm curious, like I feel like yeah, the fact that was it necrotic? Is that what they saw?
Yeah, the
That
left
is
colon was severely necrotic.
that is like mind blowing to me. Like, is it like the infection? Was it like a blood supply miss? Like, how is it that he developed like that much necrosis? And I wonder if yeah, there's something else at play in the background that we haven't caught yet. But yeah, for sure. I mean, whatever. It sounds like there was like something that triggered this chain of event, and whether there is an underlying etiology that is in the background also not helping the situation. Because like, I feel like for someone like even a 32-year-old to have like constipation as like a past medical history, like is there something there like that predisposed him to having this constipation that leads to diverticulitis? Is there something else that we're missing? I have no idea, but I think y'all are. I'm grateful he's getting such wonderful care, and I wonder with like the biopsy result from the surgery itself and just like close monitoring, what else they if anything will unmask. Well, wow, what a humbling case, and what a case to
Yeah.
in the beginning of intern year to walk into Maddie.
It was just
Ma-
quite just to get a call from the radiologist being like, there's some concerning things on this x-ray, like please stat order a CT, and then things very changed from there.
Yeah, and I think like the comments you were making, Maddie, about oh, we were gonna transition this patient
Yeah.
to like PO antibiotic. It happens so often in medicine, and to this day, there are patients that I'm like, oh, I think this patient is ready to discharge, and 5 minutes like a rapid response called,
Yeah.
and and I think that's kind of a nature of like taking care of patient in hospitals. That the reason why they're here, they are quite sick and they're very prone to decompensation, even at moments that we think we've had them stabilized. They're like such prone to like further complications or a different etiology coming up. So I hear you, friend. I constantly get humbled every day.
Totally.
Maybe,
And maybe before we go to teaching points, Maddie, I have a quick question. Do you
Yeah.
think that transverse colon ulceration is part of the diverticulitis or a separate problem?
That's a great question, and I'm not entirely sure. I'm not entirely sure what that was from. Yeah. I was kind of in my mind thinking that diverticulitis could explain a lot of the things in the sigmoid colon, like the fistulas and the strictures, and then the subsequent obstruction and perforation. But I wasn't sure about the ulcer. Yeah.
Yeah. Yeah, I think, yeah, like again, like pointing towards something that maybe it's yet to reveal itself.
Yeah.
Did he have any symptoms before that 6 days? Did he have any? Because like I can totally see diverticulitis do this, but oftentimes it's just I have never seen it rapidly evolve to such like visualization, like stenosis. Oftentimes, like it's been going on for a while, it hasn't been addressed, and it develops complications. So the fact that it just such rapidly develops, I wonder if there was something going on again in the background, then that just made it worse, the diverticulitis. I still think
Yeah.
Crohn is like it's a solid consideration still in
Hmm.
him.
Yeah, I
Yeah,
think the team was really thinking this could be consistent with Crohn's, especially, yeah, for all the reasons that you mentioned. I think we were
yeah.
surprised from the biopsy findings. And to answer your question, besides the constipation, at least when I spoke with the patient and from reading the notes, there didn't seem to be any report of prior episodes of abdominal pain, but maybe that was missed in some of the history taking, but not that I gathered.
Yeah. That's such an educational case. Thank you so much for sharing it, Maddie. Minju, what an absolute pleasure to discuss a case with you. I cannot wait to do this again.
Same here. And I think this case also reflects the reality that sometimes we don't have answer for all the findings we see. And I hope the surgical pathology could maybe tell us more about the underlying pathology, but maybe not, then we won't have an answer here for everything. But thank you so much, Maddie, for this amazing case.
An
Beautifully
absolutely
said.
amazing discussion. I love listening to you both.
Well, big shout out to Valerie for scribing and Parisa. I can't wait to hear your teaching points.
It was amazing case and fantastic discussion. Actually, it was a women's powerhouse today. Thank you, Maddie, for bringing it in. We started with a patient who presented with abdominal pain and diarrhea. We talk about that abdominal pain has a V pneumonic as a no misdiagnosis, which V is a vascular inflammation, perforation, and obstruction. We also think that we could get anatomical approach and address it from the other way. This patient specifically has left lower quadrant pain. We were thinking that we should consider colitis, diverticulitis. We also need to think about thoracic and pelvic pain that could be presented as a referral pain. We talk about diverticulitis, which is more common in older patients, but in younger patients could also happen. But these patient population usually have genetic predisposition and then have a history of constipation. This patient specifically presented with nausea and diarrhea, and we thought that this kind of presentation localized the disease to the GI tract. And when it is accompanied with distension, we need to think about obstruction. We need to think about consider gas, liquid, and solid. But in terms of time course, solid is less likely. We talk about diarrhea and think that the no misdiagnosis for diarrhea is Clostridium difficile, even in the patient who are not hospitalized, which could be community acquired. These patients are usually sick appearing. They might have toxic megacolon and ileus. We need to think about who is the patient and consider the past medical history. When somebody is coming with diarrhea, we need to truly ask about history of the exposure, travel history, toxin, and infections, and the immune status of the patient will help us to narrow down the differential. When somebody is complaining of having blood on the toilet paper, it could be because of the hemorrhoid, or maybe it is the explanation of bloody diarrhea. We need to check the hemoglobin to make sure. When somebody having a surgical procedure, we need to think about a variety of complication, including anastomosis, leak, perforation, or stenosis. When somebody having alcohol use disorder and presenting with abdominal pain, we need to also think about peptic ulcer disease, acute liver failure, pancreatitis, and consider ascites. This patient specifically has a fistula in the imaging, which is a red flag for IBDs and specifically Crohn's disease. But we know that the mimickers for the Crohn's disease are HIV-associated infection, chronic infection like TB, histoenteromoeba histolytica, NSAID colitis, and lymphoma. We know that ulcerative colitis mainly involved in the terminal ileitis, but it could be also involve sigmoid colon. And the mimicker of involvement of the terminal ileum are Shigella, TB, and Behçet. There are some mutual features between corona and Behçet, including olar ulceration and erythema nodosum, specifically in female patients, but Behçet specifically have genital ulcer. We also learned that steroid can mask abdominal exam, and when somebody is presenting in perforation, we need to keep them MPO, have a good IV access, start broad antibiotic coverage like Zosyn, have close monitoring, and put a surgical consult. We also talk about the diverticulous complication, which include fistula, perforation, abscess, and obstruction. Thank you so much for this amazing session.
Aisa, that was amazing. Thank you so much for distilling this incredible case to such wonderful teaching points. Really grateful for you. Oh, shout out to everybody. Thank you so much for joining us. We really appreciate it. We'll see you soon. Thanks all.
Thank you. Bye.